Good evening and welcome to our fourth in a series of the patient education program. Today, we are lucky enough to welcome back Irini Laura Verbist to our fourth episode. Each month, we're exploring different topics within sound sensitivity, aiming to give you a broader knowledge and understanding of these conditions. My name is Joanna Barker, and I am your host for these sessions. I have been an audiologist for the last 12 years, and I'm a specialist in misophonia, tinnitus, and hyperacusis. Sound sensitivities are my passion, and I'm really excited to bring these live sessions to you. Irini joined me in our first episode where she gave us an insightful look into understanding your condition and maximizing your therapy experience. Today, we are lucky enough to have her back discussing unlocking access, overcoming obstacles to engagement in mental health services. Irini is a research associate with Greater Manchester Mental Health NHS Foundation Trust, where her research interests lie in the impact of both physical and mental long-term conditions, stress, and psychotherapeutic therapies on individuals' quality of life. There will be the opportunity to ask questions after the presentation, so please feel free to post these through the chat function. Thank you so much for joining us this evening. Irini, I'm now going to hand over to you.
Hi everyone, thank you for having me, Joanna. Really appreciate it.
Thank you.
And yeah, I would be very happy to share my screen and start with the presentation. So let me just very quickly, yes, okay, sure. Okay, and can you guys see that? I think I've put it in.
Yeah, it's come up. If you can just possibly, that's amazing. That's perfect.
Perfect. Great. So as Joanna actually mentioned, we are going to talk about access and engagement with mental health services and more specifically with psychotherapy services. As it has been mentioned, a little bit about myself. I am a researcher for talking therapies, NHS talking therapy services, that are services that provide evidence-based interventions for depression and anxiety for people with mild to moderate mental health conditions. So we do see people with anxiety disorders like social phobia, PTSD, etc., or depression, major depressive disorder, etc. I just got a notification that my internet connection is a bit slow. Hopefully you can hear me well.
We can still hear you. That's fine.
Great, thank you. And my research is based on improving outcomes for the people who access our services. And of course, in order to have good outcomes, one needs to also access and engage with therapy services. So I have collaborated with clinicians, with senior management, and of course with patients to better understand their needs and help and facilitate the services to provide the care that patients need. So, can psychological therapies help many people? I assume have that question at the end of the day. Why should we start therapy? It seems that it does help. Of course, this is based in 2022, 2023 NHS data, and we see that regardless of the type of therapy that one has received, we see that the success rate is approximately 60%. Some of you may have heard of those types of therapy: interpersonal therapy, cognitive behavioral therapy, and counseling. Those are the most, let's say, popular NHS-based, NHS-provided therapies. So, of course, in order to have that success rate, to experience recovery from the symptoms that the client has came to resolve, they first of all need to start treatment. So they need to access the core treatment, and then second of all, they need to stay. So start and staying in treatment is pivotal to see recovery. I wanted to visualize a little bit more how the journey of someone who accesses a course of therapy in NHS talking therapies look like. But we can always find similarities with accessing therapy in a private sector. Of course, everything starts with a referral. Either it's a professional self-referral, an individual has the urge and something motivates them to either pick up the phone or go online and refer themselves in talking therapies or in another private clinic. But that doesn't mean that the client has just started therapy. So calling or attending your first session for an assessment doesn't mean that someone has engaged with therapy, of course, because that's the initial part of before you start therapy. You need to make the arrangements as to what type of therapy you're going to have, etc. So we have this part that is the accessing a course of therapy. And then we have the engagement. So once the client starts treatment, meaning that they attend sessions where they have active treatment, the patient needs to also engage until the end of the treatment. And what does it mean here to engage with treatment? That means that the client needs to, if it is agreed that the client will have 10 sessions, for example, when they do the arrangements with the therapist, and the client disengaged on the third session, meaning that they never come back, that is a sign of disengagement. Another more subtle disengagement is if there is something agreed during therapy, i.e., for the client to do some homework or for the client to do some exercises and the client doesn't follow those exercises, again, we do have signs of disengagement. Yeah, so what happens in talking therapies is actually very interesting, and this is why it's so important to improve access and engagement with mental health services. We do see that nationally there were 1.8 million referrals in NHS talking therapy services, and approximately 1 million did attend their initial assessment. However, only 672,000 started the course of treatment. So that means that we lost 1 million people on the way. So that's a very, very big and concerning number, actually, to see that there are people eligible to receive therapy, but they end up not receiving what they need. So after from the people who did access a course of treatment, approximately 65 to 70% do engage, which is good, and only 345,000 did recover, meaning that they did have a significant reduction of the symptoms that they came to the services to resolve. So recovery is usually defined when you see that the client doesn't have the symptoms, either depression or anxiety, that they used to have when they came in. So what are the reasons for people not accessing, not starting therapy? So I've grouped the reasons here, a couple of reasons here. So this is based on various types of research that I've done throughout the years. And it is very interesting to see that we do have some similarities between the barriers to access and the barriers to engagement, especially in demographic groups. So young age, being from a Black background, and unemployment as well as deprivation, there are three factors, demographic factors, that massively interrupt access and engagement with therapy services. Um, I've had some discussions with patients and ex-service users, especially from people. I've had the discussions with people from Black background who were men as well, because this is the demographic group that is the group that least accesses the service. And ask them, so what prevents you from accessing the services? And lack of trust was a big issue, as well as not being aware of what to expect. So the fear of unknown, of course, is something very important that usually it's the services that need to be able to address that fear rather than the patient themselves. And that, of course, needs to be done through information and maybe during their referral process to have some information available for the client to see what they are being engaged to. Also, something very interesting is that Black men mentioned that it's very important to them to have a recommendation from someone they know and that they trust. So, being referred from a GP to a service that they've never heard of, it's something that they wouldn't take the risk to do so. That is, of course, interconnected with stigma. Stigma, especially in people from a non-white ethnic background, is higher, as we will see. I'm not sure if I should mention it now or later, probably later, because it's about engagement. But it's very important, especially the therapist in this occasion. It's very important to the client from a non-white ethnic background. And of course, holding negative attitudes towards seeking help. Some people, again, and unfortunately, men do find seeking help as a sign of weakness. Some people think that the social support they might have is enough to help them deal with psychological issues. Of course, one thing doesn't negate the other. Having social support is really, really important in life, and social supporting people we love can be very helpful. Of course, a professional has a completely different take in how to deal with mental health issues, and it's always important to have both options if you need to. So unmet treatment preferences, as I mentioned, I do have a passion in exploring cultural barriers to therapy. Language is one of them, of course. It's quite obvious, but of course we do have, as a service, for example, we do interpreters, but still that doesn't help the client feel very much connected with a therapist usually. But it's also cultural issues. So, for example, people from an Asian background here in Manchester, we do have a big Pakistani community, and I've talked to patients from an Asian background, and I asked them about what would they expect as regards to the relationship with a therapist, and they mentioned that. And I actually asked them, would it help you to have a therapist who is from the same ethnic background as you? And they said something very, very interesting, which is, well, it could be for some people, but for some other people, it would be worse. Because of the community being so small, then people become very fearful that whatever they say to the therapist who's from the same ethnic background, that they will share with their local community. So sometimes it feels as if there is a dead end as regards to how to deal with cultural barriers, especially around Asian and Black ethnic groups. Another unmet treatment preference is the need for a different therapist or the need for a different type of therapy. Needing a different therapist, as we will see, it's another barrier to engagement as well, the therapeutic relationship not working. This is something that has nothing actually to do, or not nothing, but the majority of times is not something it's the therapist's fault or the client's fault. Sometimes it's all about the connection that it's not there. So It's really important for the client to have that in mind and not guilt themselves or not being afraid to admit that the relationship is not working for them. And of course, the service needs to be able to provide an alternative for them. So checking with yourself as to, is this relationship work for me, is a very important step towards accessing an engagement with therapy. And as regards to the type of therapy, this is something that I have actually many friends asking me, oh, I want to start therapy. Where should I go? Who should I ask? There is a massive lack of information, lack of awareness. This is something, again, I'm really trying to address those issues and help the services be more transparent as to what the client should expect. So lack of information on what therapy involves is something that can be a huge barrier. People may have no idea what type of therapies and what each one of them mean. So having that access, even through, let's say, not a leaflet, but maybe something more engaging, like a video or podcasts or any sources that can help you better understand the types of therapies that are out there and the types of therapies that could match your needs. As regards to service-related issues, the time-consuming or complex referral process, along with long waiting times, again, they are very much NHS-based issues. Unfortunately, this is due to lack of resources. This is, unfortunately, a systemic issue that every service individually is trying to mitigate with various strategies, of course, but the demand is high and the workforce is not enough. So this is something that it's a constant battle to lower waiting times and allow people to see someone in less than a month. And of course, if someone has the majority of those characteristics that we mentioned earlier, and they need to wait, and they also lack of trust in mental health services, they're not gonna access a course of treatment. It's unavoidable to lose them, basically. So what happens and what are the barriers for people who do manage to access a course of treatment and they do see a therapist regularly? So we have seen and we have noticed, and when I say we, I mean the community of researchers, we do see that between the second and the fourth session, the potential or the possibilities for someone to drop out is the highest. So the majority of dropouts happen somewhere there between the second and the fourth session. Having that information is very much important, especially for someone who is a therapist, and that is because therapists become more vigilant to see the signs of disengagement, and that would help both to actually reevaluate what's going on, if everything works for both, etc. So person related, again, someone who is of young age or from a Black background, high deprivation, unemployment, are the usual suspects for disengagement. High deprivation and unemployment, especially unemployment, has been a very well-established factor for not engaging with treatment. And I remember a client telling me, well, I don't understand. They don't have people who are unemployed, they have more time. So how come they don't engage? Which is a great, actually, question. But the interesting thing is that when someone who's unemployed is dealing with covering their survival needs, so basic needs like food and housing and safety, the motivation and the energy and the time that it takes to engage with therapy is not there because it's everything else is prioritized because the basic needs need to be met. And that's why, for example, in the services that are in NHS, in talking therapy services, we do offer some employment advice. We have employment advisors actually to help people better address those needs as well, and then engage with therapy, because one would fight the other. And the therapist can't do their job, but they still need support. So there was always a dilemma there. And then last but not least, low motivation to change. This was one of the first research that I've done in psychotherapy services. It is not very surprising that people who don't seem to be very motivated to change, and that can be defined as I don't think it's important and I don't think it's feasible to change. So those two, feasibility and importance, like having the control over change, plays a significant role in engagement and recovery, of course. And that is again something that, of course, this to some people it just happens. There is an intrinsic motivation to change. To some people, it comes later during therapy, and of course, a good therapist can understand whether a client needs a little bit more motivation or a little bit more understanding as to what's going on and what are the benefits of being in therapy. So this is always very much important, if you are already in therapy, to remind yourself, why am I doing this? Why is this important? And what will I achieve from being in therapy? As regards to clinical characteristics, we do see that people who present higher levels of anxiety and depression, they seem to disengage early. And that's again counterintuitive, because you would expect, well, these people need therapy more, and it's true. But however, they don't really have their expectations in the right place. So this is again lack of awareness. Therapy is not a pill. It's not something that will give you immediate results, and it's something that it seems to be going under the radar for some people. So basically, depending on the issues that you have and the plan and the treatment plan that is in place, therapy, you will see the benefits of therapy probably in the long term. So it takes a little bit more time, and expectations need to be discussed in the initial sessions, so the client understands what to expect, to have realistic expectations, basically. Because if you don't know what really to expect, then you will think that nothing is working, basically, and that's why you disengage. And then we have some groups of people. So I'm not mentioning this here, but for example, people with long-term conditions, with physical long-term conditions, such as diabetes or COPD, these people seem to be engaging more. And that's very interesting, because it shows that there is a high demand. People who also suffer from a physical condition, they seem to be engaging more because they need more support to deal with the treatment adherence, etc. Unfortunately, they recover less, and that's a big issue that I'm trying to focus my research on at the moment. But what happens with other groups, we see exactly the opposite trend. We see that people with disabilities and people belonging in the perinatal group, meaning that they either are pregnant to give birth, or they have perinatal issues, they seem to disengage. And the reason for that, or at least anecdotally, or from qualitative from qualitative data like interviews and focus groups, when we ask people why that is because some types of therapy, like CBT, need to be adapted to this group in order to work. So what happens is that we do have very robust interventions out there. There is a very well-established evidence actually around the effectiveness of the types of therapies that we have, but not all therapies can go to everyone. For example, I remember disability champions. So we call champions the therapists who focus on one group of people. So we have a better insight into the needs of those people. So they were saying that it's impossible to ask from someone who has ADHD that they have a shorter attention span, to do a homework that needs to be every day, more than half an hour of focus, etc. So what happens here is that CBT would work really nicely if the person didn't have ADHD, but they do. And this is not something that we should just omit and say, well, we can't do anything about it. We can. The reason is that we need to adapt the actual intervention to meet the needs of these groups. And then as regards to treatment-related issues related to barriers to engagement, is the poor relationship with the therapist, as I mentioned earlier. This is again something very important for both access and engagement, is to have, of course, to give time. So a first session is a good idea of what the relationship will look like, but it's not the full idea. So usually it's recommended to give yourself 3 to 4 sessions to better understand whether the relationship will work for you. And I think that comes from the therapist perspective as well, because it might be the case that the therapist cannot provide the client with the help that they need. Therapy not meeting expectations, we talked about that. Expectations are very important to be discussed right in the beginning, along with the type of treatment. Of course, mistakes happen and people think they could engage with counseling, but then they just think it's not too suitable for them. So this is again the importance of re-evaluating how things are going, especially in the initial sessions, like the first 6 sessions. It's good both for the patient and the client and the therapist to discuss and revisit what they've talked about and what they have agreed in case there needs to be some adjustment. So the bigger picture here, like the big take-home message is access and engagement. Of course, access is a prerequisite for recovery, and engagement is also a very big factor for recovery. So if someone needs support, it's very important to get the support that they need in order to see a positive change in their lives. But one thing that can happen is to personalize treatment a little bit more, to meet the needs of all these different groups of people who do need the support of mental health services. So we are now, University of Sheffield, actually, a great team is doing work on personalized treatment a lot. And then I am part of their trial, but which is actually still running. But they did have some findings on using old patients' history. And they developed an algorithm and they trained the algorithm to understand which client with depression is better allocated to have CBT and which one would be best with counseling. So, depending on some characteristics, for example, people with disabilities work better with counselors. So it's interesting to see that using the technology, AI technology, along with personal characteristics that one can very easily found in the records, we can better decide what type of therapy would suit that person best. And they tested this algorithm in all cases to see, okay, so if we follow the algorithm, what is the success rate? And if we don't follow the algorithm, what is the success rate? And we saw that 60-40 success rate accordingly. So people who received a personalized treatment plan, they had 60% success, whereas the people who just received the treatment that they were allocated, it was only 40%. Practical steps for therapy engagement. So I think this is a very important bit of this presentation. It's very important to me in general, and when I meet with clients and members of the public to always talk about not only the problem, but also what can be done. So, for example, personalized treatment is, and all the research around it is the work of the researchers, including myself, to bring to the service and improve outcomes. But as a client, what can you do to enhance engagement? So being open, of course, being vocal about your preferences with your therapist is very important. I understand that sometimes can be quite difficult to express oneself and say what you think or what you need, but you need to remember that the therapy environment is a very safe environment. And of course, the reason why you're there is to be supported. So understanding your needs and then being able to communicate your needs, share your therapy goals, and of course, asking questions is very important. Sometimes we tend to disregard a process because we don't really understand it. So asking questions, sometimes therapists forget that someone might have no idea what a therapy session look like. So it's very important to ask any questions or informations on types of therapies, especially even before you pick up the phone and make a phone call to a therapist. Try to find as much information as possible to feel a little bit more confident towards that next step. It's a very personal decision. It's not something that it's very easy to be done. Sometimes takes years to make a decision around therapy. So it's important to feel that you have all the information you need. As regards to what services can do to support clients, well, reduce waiting times is something has been an ongoing issue for a while. And of course, I've talked to patients who have been referred to the services and they never came for an assessment. So these are the clients who we received their referral, but they never called us. And I tried to find some of those people and ask them what happened, why you didn't call. And they said, well, I lost a letter or they didn't pick up. So even practical issues that sometimes NHS doesn't meet. And of course, I'm very thankful that these people, quite a few of them said, well, we went to a private practice and now we are doing fine, which is great to hear. But I understand that not everyone has the means to see a private and to be in a private clinic. Training to therapists in general is very important to improving their skills, to understand the importance of building trust and communicate very clearly to the patient around things around confidentiality. I had many patients telling me that they were afraid that their employer will find out that they are doing therapy. They were very much afraid of professionals talking to each other about their issues. So this is very important to communicate to the client that everything you say is confidential and that will never change. And as regards to check-ins are very important. We have now very recently embedded a tracking method in the progression of the client. So we are trying to, if the client doesn't follow a trajectory towards recovery, there is a kind of a little alarm to the therapist that something is off, and the client seem to either remain stable, their symptoms are stable, or the symptoms are actually worsening. So then the therapists are being urged to talk with the client about the progress and what they need, and it's a sign that the client is probably not responding to the therapy. So it's very important to check in again, reevaluate your contract as we call it with the therapist, and see if everything works for you, and if not, what can be changed as soon as possible. So, and especially from the therapist side, so you don't lose a client and they lose faith in therapy, which is quite detrimental. So that was all in all. I would love to hear from you, and if you would like to share some insights as regards to accessing or being motivated to start therapy, what would make you, what would actually help you to stay engaged if you had started therapy, or what would make therapy feel more accessible to you. Anything that you would like to share, would be more than happy to discuss. And of course, if you have any questions, again, very happy to discuss.
Brilliant. Thank you so much. That was amazing. That was excellent. I have a few questions, if that is okay. We haven't had anything come through live just currently at the moment. Um, you were looking at your last slide was asking obviously our audience if there was any feedback that they have. Is this something that you look at, that you ask patients in regards to what improvements that can be done to services? And if so, how do you go about asking patients?
Yeah, well, this is something that I'm very thankful that is has become a priority for the NHS and the National Institute of Health Research, and it's called PPI, patient and public involvement. So now, patient and public involvement becomes a priority because we want to bridge the gap between the patients and the services, because up to 2015, let's say, all the decisions would be made from senior management, and patients would have no voice towards those decisions that are very, very important for how the services work and operate. So, since this has become a priority, I'm trying to embed in every research project I do. I'm trying to run a group. So usually, because I did mention a lot of feedback that I got from patients, so usually that takes place in the form of a group. It's usually online to facilitate access, and I usually share some findings. For example, I've shared some findings for access and engagement from the research that I did in 2022. And I presented the problem, and then we had an opportunity to discuss of potential solutions. One of the solutions, for example, as regards to admin and vote and calling and then not responding, was from a couple of patients who said, "Why don't you have an online system to allow the clients to book their appointment by themselves?" And that actually, 2 years later, it did happen, which is great. It's great to see. But one of those recommendations, for example, practical recommendations, sometimes it's cultural recommendations. Now I'm actually looking to run a BPI group to ask about long-term conditions and around the needs of people who have a physical condition, like, for example, tinnitus could be one of them. It's so important, and as a researcher, patients will give you invaluable insights into what you need to do and what your next research priorities should be. So that's the main reason.
Excellent. Yeah, and sometimes, especially obviously in the NHS, these processes do take some time to until they're activated. Um, and I don't really see an issue in that as long as it's actually being done and it's actually being rolled out to patients. And something like that would be incredible in our services because we have lots of hard of hearing patients, lots of patients who can't actually hear if the phone's ringing or can't hear if somebody is on the phone, or, they might, um, if they have hyperacusis, they might not actually have a ringer on their phone or might not actually like speaking on the phone. So, this is not only being allowing patients to access treatment more effectively, but it's being more inclusive as well, isn't it? So
Definitely.
that's great to hear. Hashir actually had a question himself. So his question starts in ancient Egypt over 3,000 years ago. The concept of healing through words has been documented. So this is historical root for talking therapies. CBT also has its roots in Greek Stoicism over 2,000 years ago. there can be some ancient attitudes in talking therapies. For example, the person needs to want it, or the person should have willingness to accept the problem. Also, modesty in presenting the benefits of the therapy. Could these ancient attitudes of talking therapies be considered as barrier to modern human beings in engaging with them? Could these attitudes be modernized?
Well,
He actually
that's
says he doesn't, he's not entirely sure how, but we're looking into how can we modernize these ideas of talking therapies, and are we doing that already?
which types of ideas? So you're talking about the idea of, because you mentioned about talking being in ancient Egypt or aspects of CBT being in Stoicism. So these are already embedded in the therapy practices. So what other types of practices are the ones that would be embedded?
So the could these ancient attitudes of talking therapies be considered as a barrier to modern human beings in engaging with them? So I suppose he's asking, are we these talking therapies have such a rooted history? Are we modernizing them as we go, or are we staying with those ancient sort of ideas? And if we are modernizing them as we go, are they relevant to our society at the moment?
Yeah, that's actually a very good question. I feel a constant reevaluation of what is it that we provide is always the key. Of course, that's my job, so I wouldn't, I couldn't say something else. Like it's not important to evaluate anything. It's definitely important. It's quite the balance between not wanting to reinvent the wheel and not being close-minded. It's very thin and it's very difficult to achieve, but I think it is the key to success. So some things that we know that they work, they definitely need to stay. But some things, of course, as humanity evolves, definitely needs to adapt. I'm not. I prefer to always use the word adapt rather than changing. As we mentioned about people with disabilities, for example, I also believe personally that the use of social media has changed a lot on attention and the type of information we receive. So we definitely need to adapt the therapies that we provide. Or we need to start kind of providing more collaborative care. That's my personal belief that I feel that collaborative care should be key. So treating mental and physical health together and not differentiating the two types of a problem. So I would go towards more there. And I feel that ancient Greece was actually doing this. So maybe we should follow
So
them.
that leads like perfectly into his next question, actually, was does physical exercise help with engaging in talking therapies? And you're obviously saying let's combine them. Let's look at physical and mental health in one. So would this, do you feel like this would be productive?
Well, I have actually a colleague and an ex-colleague of mine who is doing a lot of research on physical exercise and talking therapies. And they have been trying to understand the impact on recovery, not even engagement. But I suspect that physical activity is definitely key in mental health, and it would be positive. It would have, in my opinion, a positive impact on engagement. And the reason why is because that's something on health psychology. Because my background is on health psychology, so there is a way of thinking as regards to benefits. There are some people who focus on short-term benefits and long-term benefits. Physical activity is for sure an activity that gives you long-term benefits. There are some short-term benefits, like you feel euphoria after running 2 miles, but the majority of the benefits are long-term. So I feel having that, not discipline, but maybe patience and invest to your physical health and be able to see that I'm now investing. I'm not waiting for something. I'm not waiting to lose weight tomorrow. I'm just investing on myself. That mindset would definitely help the mindset of investing into your mental health. So I think there would definitely be uh, an association there.
And I suppose if you have the dedication to be able to commit yourself to exercise, like going running every day or trying to investing in yourself to lose weight through fitness, then presumably that's a transferable skill to investing in your own mental health and therefore engaging and continue with talking therapies as well, isn't it?
Yeah, that's definitely it. And it's all about intrinsic and extrinsic motivation. It's another interesting uh, difference as regards to an extrinsic motivation is if, for example, a friend of yours will tell you, well, I don't know, I will love you more if you exercise every day. The chances that you discipline yourself are lower than if you tell yourself, well, I want to change. It's time. There are
Yeah.
many people who I've heard that they woke up one day and it is as abrupt as that. They woke up one day and they said, it's time to change.
Yeah.
So, yeah, that's a big difference.
That's amazing. You touched on sort of cultural issues, the fact that some patients may want to feel represented within the healthcare system before they feel like they can maybe open up to someone or trust someone. Do we feel like there is a spread, a sort of among culture and sex in terms of actual therapists? So in the NHS system, are we sort of culturally representative of the population?
Well, that's a very good question, and that is something that I have been discussing with the ECDC champions, as they call it, which is the champions that represent EDI, so equality, diversity, inclusivity, and it has been. We do really trying to understand whether the if I understood correctly, whether the clinical staff is representative of the population that they serve,
Yeah, yeah,
which is exactly that's why it's so important because again, people from an Asian or a black background will say, "Well, I went to those services and everyone was white, and I didn't feel very comfortable." Or the same with groups. There is certainly there is a motivation to do so and have representative staff. As regards to genders, though, there is definitely a higher female rate in this. But this is something that it,
and
yeah,
it's the same in audiology. Obviously we have a sort of a background in sort of we delve and dip into talking therapies, but essentially, obviously, we are audiologists, and we're a heavily female dominated population. So, that is difficult because it's the same in talking therapies, access to any health care. We want people to engage with the therapist so that either they can be successful in counseling their tinnitus, hyperacusis, or misophonia, or even just giving them the confidence to wear their hearing aids. And I suppose, do you think that's down to recruitment or again, sort of
it's
understanding of services, advertising to different populations?
true. I think advertising plays a significant role both in recruiting clinical staff or approaching patients, potential patients. As regards to, well, there's nothing much people can do rather than just having this as a given that the population needs to be representative. But then there is another question as to whether it would be good for the client to have the choice to choose or not. So this is a dilemma, both in from a clinical perspective, but from a research perspective as well, because we don't really know yet if it would be the ideal for the client to say, I would like someone between the 30s and the 40s, male from this background. We're not sure that this would work because sometimes it's not the we don't really know the underlying mechanisms of the relationships that work. And it might even be the case that today, as I am, best therapist I'd have would be someone in the 60s, and 2 years from now, best therapist I could have is someone in the 30s. We don't really know. It's something that changes, I feel, all the time. So
Yeah.
sometimes it's not under control. Like, yeah.
And essentially, obviously, if we were to then put these stringent criteria on what patients want from a therapist, we're then elongating waiting times even more, really, aren't we?
Oh,
So,
massively.
um,
Massively.
so
Yeah.
we're in essentially we're locking access to therapies even more than we
Mhm.
currently are at the moment. So I suppose it's always trying to just give patients um as much information and as much as we possibly can support them in those ways. And Sharon had another question for you. You talked about personalized treatments. His question was, how do we ensure, like, when using personalized treatment, that we don't lose the essential components in talking therapy? So, for example, in CBT.
Okay, so personalized treatment is basically more about what is the type of treatment that would benefit the client with XYZ characteristics. So CBT as it is doesn't really change. At the moment, we are at the place where we are trying to identify the right intervention for the right group of people. So there is CBT, counseling, interpersonal therapy as the main ones, but there are 200, I think, 200 and something type of interventions out there. There are quite a lot of interventions. So we don't really need more interventions. What we need is actually allocate the right person to the right intervention. So the intervention stays the same, but we just make the right connection. And for example, people with disabilities who can't really deal with CBT homework, it might be the case that we don't really need to adapt the CBT model, but we can just find another type of therapy that would be more suitable to this group of people. Which is, yeah,
It
it's a
makes a
vision.
lot of sense, doesn't it? And I suppose, that's great. That's exactly what you want is a protocol essentially, isn't it? This patient comes in to see us with this problem, so therefore they're going to have this therapy.
That's yeah,
Is that what you're sort of working on at
yes,
the moment?
yes.
That's
Which
incredible.
is exciting. Our service in Trafford is actually, I'm the principal investigator, meaning that I represent the trial for this service. So I don't belong to the team in Sheffield, but I do help them um, to actually do the work. And what happens now, we have 4 clinicians who use an AI app on the phone. And what they need to do is when they assess a client, they add in this app 6 to 8 features of that client. And when I say characteristics or features, I mean very basic ones: age, gender, um, postcode, simple things, some demographic and some clinical details. And then the app says this client would be a better match for counseling or a better match for CBT. And the clinician follows that advice, of course, after just agreeing with the app. So if the clinician for some reason doesn't agree with the app, it's absolutely fine to just go with the clinician's uh, expertise and opinion. But other than that, they follow the recommended intervention. And probably in 2026, we'll find out if that worked.
That's brilliant because that's
So,
very similar to I suppose so like the app Better Health, so private talking therapies do something very similar. You put in this is how you like to learn, or this is what you prefer to do. How do you express emotions? And they will sort of go, right, okay, actually, this rather than what therapy, they sort of maybe go, this is what therapist, and then it's down to the patient to go, okay, I've read about this therapist. Do I feel like this is what I want, or should I choose something else? And obviously, in private healthcare, you have that option to be a little bit more picky, and have more choice. But it's good to be able to bring some of those ideas across to the NHS. And essentially, what you're describing, the work that you're doing right now, is hopefully going to cut down so much time and so much energy, and hopefully stop patients from disengaging because they're actually accessing the wrong therapy.
Exactly that. And it's so important. Those type of issues are quite systemic. So it takes time to understand the solution, takes time to adjust the solution. Sometimes it might even be the case that the client doesn't know that this type of therapy don't doesn't work for them.
Yeah,
And I could say that this is the majority of times that they don't know because they don't even know that there was another option. And that's why transparency to me, I'm the biggest advocate for transparency. I've actually produced myself an animation video on becoming more transparent in the referral process. I feel information is key. Being better understanding what everything entails, then you can have an informed decision as to, okay, this doesn't work for me, not this therapy. This could be the room I prefer online. This could be the therapist I prefer a different therapist. This could be the type of therapy. So all these little things could be adapted rather than for the client to say, I'll never try therapy again, it doesn't work.
yeah,
And I had friends, unfortunately, I had a friend, I remember before I had this job, I had a friend who said, oh, I went to the NHS and I saw a counsellor. She would never see me again. I was like, why? What happened? It's like, oh, this is not for me. But this is what is this? What do you mean by this? It was just that session that was not for you. This is
yeah,
very important to keep in mind. That it's not a rejection completely of talking therapies.
yeah. That's
Mm.
so important. Oh, it sounds incredibly interesting, the work that you're doing, and it's going to have such a big impact for patients and for the healthcare service as well. You're going to be reducing so much work. So best of luck to you.
Thank you.
That's
Thank
really
you so
exciting.
much.
Hopefully, maybe we can get you back in again once that's all done to explain
Yeah,
it all to
definitely.
us.
That would be
Perfect.
amazing. Thank you so much,
Thank
Joanna.
you so much for joining us again, Irini. I really appreciate it. That's brilliant.
Thank
For
you.
anybody who has been having any problems with any of the issues that we've raised today in our patient education program, please feel free to get in touch with Hashir International. Our website provides lots of interesting resources for patients, families, and healthcare professionals. The main aim for Hashira International is to provide private consultations and clinics delivering specialist care to children and adults with misophonia, tinnitus, and hyperacusis anywhere in the world. We offer a premier therapy package which compromises targeted cognitive behavioral therapy for misophonia, tinnitus, and hyperacusis, combined with consultations with a multidisciplinary team of audiologists, psychologists, occupational therapists, and neuroscientists. Evaluated research on this package has shown very good results in helping patients to manage their symptoms and significantly improve their quality of life. Thank you so much for joining us this evening. Perfect. So I've read it. I've just finished the stream. Thank you so much. That was
Thank
absolutely
you.
incredible. I really appreciate it.
Thank
But that
you.
is brilliant. Thank you. Have a lovely evening.
You too. You too.
Brilliant.
Rest
I'll
and
speak to you
have a good week.
soon.
Yeah,
Thank you.
same to
Bye. Oh,
you.
happy Christmas as well.
Oh yeah, of course. Happy holidays.
Yeah.
See you
Good
later.
luck next year with your application. Let us
Thank
know how you
you.
get on.
I really need that. I really need that. Thank you
You'll
so
be great. You'll be
much.
great. Thank you very much.
Thank you. See
Bye.
you later. Bye.